Hello everyone and welcome to our module on pyrimidine metabolism. So by way of review, the nucleotides can be divided up into the pyrimidines or the purines. The purines all have two rings, and I talk about those in a separate module. In this module, we are going to talk about the biochemical synthesis of the pyrimidines, which all have one ring, and the three pyrimidines are cytidine, thymidine, and uridine. So the goal of the biochemical pathways for pyrimidine synthesis is to create the monophosphate versions of the three pyrimidine nucleotides. So either cytidine, thymidine, or uridine, all in their monophosphate form with one phosphate group attached. The ingredients the body is going to use to create these molecules include a ribose phosphate, which will come from the HMP shunt, some amino acids, which we'll talk about in a minute, and then some carbons, which come from tetrahydrofolate and carbon dioxide. Step one in the synthesis of pyrimidines is to make a molecule called carbamoyl phosphate, and this is the structure of that molecule right here. It is synthesized from the amino acid glutamine using carbon dioxide and also ATP. Anytime you see a phosphate group like this get added to a molecule, it always comes from ATP. ATP is a phosphate carrier for biochemical systems in the body. The enzyme that does this step is called carbamoyl phosphate synthase 2. This enzyme is found in the cytosol. You should know that there is a carbamoyl phosphate synthase 1 enzyme that's found in the mitochondria that is important as part of the urea cycle. And this enzyme is important in pyrimidine synthesis because it's the rate limiting step and it's inhibited by UMP. So when there are high levels of uridine monophosphate, it will inhibit this enzyme to slow down pyrimidine synthesis when the body doesn't need any more pyrimidines. Another item you should note here is that in pyrimidine synthesis, the body synthesizes the ring first and then adds the ribose sugar, and this is the opposite of purine synthesis where the ribose sugar is synthesized first. Step two is to make orotic acid. This is the chemical structure of orotic acid on the screen here. And if this looks familiar to you, that's because this portion of the molecule right here is uracil, the base that is found in uridine. So we are now very close to having our first pyrimidine base created, and that is the base uracil, and that comes from orotic acid. Step 3 is to make a molecule of uridine monophosphate, and this is done by combining orotic acid with the molecule phosphoribosyl pyrophosphate, or PRPP. PRPP may be familiar to you from purine synthesis. This molecule is important both for pyrimidine and purine synthesis. For our purposes here, it's going to be added to orotic acid in order to create a molecule of uridine monophosphate. This is done using an enzyme called UMP synthase. UMP synthase is sometimes described as a bifunctional enzyme or bifunctional protein. That's because it catalyzes two steps in the conversion of orotic acid into uridine monophosphate. So here's a summary slide of key points to remember about pyrimidine synthesis. Uridine monophosphate is synthesized first. CMP and TMP will be derived from uridine monophosphate. We'll talk about that in a minute. So you begin with the amino acid glutamine, you convert it to carbamoyl phosphate, and that is converted to orotic acid, which is then converted by the bifunctional enzyme UMP synthase into uridine monophosphate. There are, of course, many more steps than I've shown on the slide here, but I have summarized them into the most important ones that you need to know as a medical student. All of the pyrimidine rings are made up of 6 molecules, 2 nitrogens, and 4 carbons, and they like you to know the source of those molecules for your boards. So basically half of the ring comes from carbamoyl phosphate and the other half comes from the amino acid aspartate, which is added in the step where orotic acid is synthesized. There is a rare condition that ties in with the initial portion of the pyrimidine synthesis pathways, and that condition is orotic aciduria. This is an autosomal recessive disease where children are born with a defect in the UMP synthase enzyme. As a result, they have buildup of orotic acid and loss of pyrimidines. If we go back to our overview slide, in orotic aciduria, you have loss of function of the UMP synthase enzyme. As a result, the levels of orotic acid will get high, and you will have low levels of all the pyrimidines that are derived from orotic acid. The key findings of this condition are orotic acid in the urine. That's why it's called orotic aciduria. In addition, children born with this condition have megaloblastic anemia. So megaloblastic anemia is where there are decreased numbers of red cells. Obviously, that's why it's called anemia, but the red cells are large. In addition, a characteristic finding of megaloblastic anemia is hypersegmented neutrophils, and there's a picture of one in this slide on the screen here. Now, the most common reason people develop a megaloblastic anemia is because of B12 or folate deficiency. We'll talk about that later in this module. But the classic finding in a child born with orotic aciduria is a megaloblastic anemia that does not respond to B12 or folate. In fact, when this disorder was first described, it was described as a series of children who had megaloblastic anemia that could not be cured by giving these two vitamins right here. In addition to megaloblastic anemia and orotic aciduria, these children will also have growth retardation. The treatment is to administer uridine to the child, which will bypass the uridine monophosphate synthase enzyme. If we go back to our overview again, this enzyme is dysfunctional in orotic aciduria, but if you give uridine, that can be converted into uridine monophosphate, bypassing the enzyme, and from the uridine monophosphate you can make the other pyrimidines. So the easy way to keep this disorder straight is to just think of the letter U whenever you think of orotic aciduria. That will remind you that there is orotic acid in the urine. It will remind you that UMP synthase is the enzyme that's dysfunctional, and it will remind you that uridine is the therapy for the disorder. There is another metabolic disorder that causes high levels of orotic acid to occur in the plasma and in the urine, and you don't want to confuse that with orotic aciduria. That other disorder is a deficiency of the enzyme ornithine transcarbamylase. This is an enzyme that's very important in the urea cycle for metabolism of ammonia into urea. It combines carbamoyl phosphate with ornithine to make citrulline. Remember that carbamoyl phosphate plays a role in both the urea cycle and in pyrimidine synthesis. So if you have an OTC deficiency, you will get very high levels of carbamoyl phosphate, and those molecules can be converted into orotic acid to give you high levels of orotic acid. If we go back to our overview slide here, in OTC deficiency you get very high levels of carbamoyl phosphate, and that gets converted into orotic acid and gives you high levels of this molecule as well. But the reason for the high levels of orotic acid is very different from in orotic aciduria, where you have dysfunction of the UMP synthase enzyme. So since they both cause orotic acid to appear in the urine, how are you going to tell them apart? Well, only in an OTC deficiency will you have high levels of ammonia, and that's because the urea cycle is dysfunctional. And you may know that ammonia can cause an encephalopathy. This is how liver disease patients get hepatic encephalopathy. So babies born with this condition will have lethargy and coma, all from high levels of ammonia. So when you see that the ammonia level is high, you know that you are not dealing with orotic aciduria. Instead, you are dealing with an OTC deficiency. So now that we understand how uridine is synthesized, let's talk about how the other pyrimidines are derived from that molecule. So if we start with uridine monophosphate, we then add a couple of phosphates to it using ATP to create uridine triphosphate. From uridine triphosphate, cytidine triphosphate can be synthesized. It involves removal of an oxygen group and addition of a nitrogen group. There is a chemotherapy agent that mimics the structure of cytidine, and it's called Ara-C. It also goes by the name cytarabine or cytosine arabinoside. If you look at the bottom of the screen here, on the left is the molecular structure of Ara-C, and on the right side of the screen is the molecular structure of deoxycytidine. You can see that they are very similar, however there is an oxygen group oriented incorrectly and pointing up in the molecule Ara-C. Once this gets into the body, it will be converted to Ara-C triphosphate by adding 3 phosphate groups to this portion of the molecule. Once this occurs, it will mimic deoxy-CTP. It's called a pyrimidine analog, and this will bind to DNA polymerase and inhibit the enzyme. And that's why it works as a chemotherapy agent, because it blocks the ability of cancer cells to reproduce their nucleic acids and multiply and divide. For the remainder of this module, we're going to talk about the final pyrimidine, thymidine. And as you know, thymidine is only used in DNA, so the body only needs deoxythymidine. It does not require the ribonucleotide thymidine. And thymidine is synthesized from deoxyuridine. They have very similar structures. If you look down at the bottom of the screen here, this is uridine on the right and thymidine on the left. And they are almost the same structure except for one extra carbon that is added to thymidine. So as we will see, all the biochemistry in synthesis of thymidine involves adding a carbon to uridine to create the molecule of thymidine. Step 1 in the synthesis of thymidine is to take uridine monophosphate and convert it to deoxyuridine diphosphate. So we start with uridine monophosphate shown here. We add a phosphate group which comes from ATP, and then the enzyme ribonucleotide reductase can work on any diphosphorylated ribonucleic acid to remove the OH group from the 2-carbon and create deoxyribonucleic acids. So once this OH group here is removed, we now have deoxyuridine diphosphate, and that is step 1. There is a drug that inhibits the enzyme ribonucleotide reductase, and that drug is hydroxyurea. This will block the formation of deoxynucleotides, although it will leave RNA intact. This is rarely used for malignancies, but more commonly it's used in polycythemia vera and essential thrombocytosis. In both of these conditions, you have either too many red cells or too many platelets, and this will block the formation of the nucleic acids that are required to synthesize more of these cells. It's also sometimes used in sickle cell anemia, but this is for a very different purpose. This drug causes an increase in fetal hemoglobin levels. The mechanism of this is not clear, and for this reason you will see many people who have sickle cell anemia on hydroxyurea in order to increase their levels of the more functional fetal hemoglobin for those patients. Step 2 in synthesizing thymidine is to remove a phosphate group and convert deoxyuridine diphosphate to monophosphate. I've not shown that on the slide here, but once you do this, you will be left with a molecule called deoxyuridine monophosphate, which just has one phosphate group here. And then step 3 is really the most critical step. This is where you convert deoxyuridine monophosphate into deoxythymidine monophosphate. And in order to do this step, you use an enzyme called thymidylate synthase, and you add one carbon right here to the uridine to create thymidine. The reason this step is so important and the reason it's so highly tested on step 1 of the boards is because it involves the use of the vitamin folate. So folate can be converted into a molecule called N5-N10 tetrahydrofolate, and that is the source of the one carbon right here that gets added to uridine to create thymidine. It is actually this carbon right here on the tetrahydrofolate molecule that gets transferred to uridine to turn it into thymidine. So there are several compounds derived from the vitamin folate that are involved in this final step of synthesizing thymidine. So let's talk about all those compounds now. So this is the structure of folate. You can see that it's a large structure with several rings. If you add 2 hydrogens to the folate molecule, you will have dihydrofolate. That's why it's called dihydro, because 2 hydrogens have been added. And those 2 hydrogens get added to this ring right here, and when they're added, you remove a double bond. So this ring in folate has 3 double bonds, and in dihydrofolate, it only has 2 double bonds because we have added 2 hydrogens. If you add 4 hydrogens to the folate molecule, you will then only have 1 double bond in this ring here, and that's because 4 hydrogens have been added to remove 2 of the double bonds. So all these structures look very similar. Their main differences are in this one ring right here and the number of double bonds that are present. Tetrahydrofolate can then be converted to N5-N10 tetrahydrofolate by adding a carbon right here that connects over to here, and you can see that carbon in this molecule down right here. And that is the carbon that is going to be donated to uridine to create thymidine. So the reason I went through all that chemistry of folate for you is because you need to maintain the levels of N5-N10 tetrahydrofolate in order to have a ready supply to convert uridine into thymidine. And the way levels of this molecule are maintained are by taking folate from the diet, converting it to dihydrofolate, and then to tetrahydrofolate, and finally into N5-N10 tetrahydrofolate. The enzyme that converts dihydrofolate to tetrahydrofolate is called dihydrofolate reductase, and I've bolded this in purple here because we'll talk about in a minute how there are some drugs that inhibit this enzyme. You also should know that folate compounds are often described as one-carbon carriers. That's because they often serve a purpose just like they do here. In thymidine synthesis, they donate 1 carbon to the molecule uridine in order to create thymidine, and these compounds often donate 1 carbons to other structures that need them. There are a number of drugs that inhibit the conversion of uridine to thymidine, and the first one we're going to talk about is called 5-fluorouracil, or 5-FU. This is a chemotherapy agent that mimics the structure of the base uracil. That's why it's called 5-fluorouracil. If you look at the bottom of the screen here, I've shown you the structure of uracil, and at the top is 5-FU, and you can see it has a fluoro group attached. Inside of cells, 5-FU is converted to 5-F-deoxyuridine monophosphate. This is an abnormal version of the nucleic acid deoxyuridine monophosphate. This abnormal version will bind both the N5-N10 tetrahydrofolate molecule and the enzyme thymidylate synthase. Once those two are bound, this will result in inhibition of the enzyme thymidylate synthase. As a result, cells cannot produce deoxythymidine, and they will die of what's called a thymin-less death. And that's why it works as a chemotherapy agent, because it blocks the ability of cancer cells to synthesize thymin so that they can multiply. The next drug we'll talk about is called methotrexate. This is sometimes used as a chemotherapy agent. It can also be used as an immunosuppressant. If you look at the bottom of the screen here, you can see the chemical structure of folate, and you can see that methotrexate looks very similar. It has an extra group added right here. It also has a nitrogen here where folate has an oxygen. So it's got a very similar structure to folate, and what it will do inside of cells is mimic dihydrofolate and inhibit the enzyme dihydrofolate reductase. As a result, this will block the synthesis of deoxythymidine monophosphate. If we go back to our overview slide, methotrexate will inhibit the activity of dihydrofolate reductase. As a result, dihydrofolate will not get converted to tetrahydrofolate. You will have lower levels of N5-N10 tetrahydrofolate, and you won't be able to convert uridine into thymidine. Cancer patients who are given methotrexate can suffer from bone marrow suppression, and the bone marrow can be rescued by giving a drug called leucovorin, which is folinic acid. This is a drug that's converted to tetrahydrofolate inside of the body, therefore bypassing the dihydrofolate reductase molecule. Back to our overview slide again. So cancer patients who have received methotrexate will have inhibition of this enzyme, and if they develop severe bone marrow depression, they can then be given leucovorin or folinic acid, which is directly converted to tetrahydrofolate, bypassing dihydrofolate reductase. This will resupply the body with N5-N10 tetrahydrofolate, and therefore the bone marrow cells can begin synthesizing thymidine again. Another tie-in with this step of pyrimidine synthesis is the sulfonamide antibiotics. So bacteria cannot absorb folic acid. They have to synthesize it, and they synthesize tetrahydrofolate from a molecule called para-aminobenzoic acid, or PABA. And the sulfonamide antibiotics have a very similar structure to PABA. If you look at the bottom of the screen here, on the left side is a sulfonamide molecule, and on the right side is a PABA molecule. They look very much alike. So when bacteria are exposed to sulfonamide antibiotics, they will not be able to make tetrahydrofolate. As a result, there will be less tetrahydrofolate inside of the cell, and the bacteria will not be able to synthesize deoxythymidine monophosphate. They will lose DNA synthesis. Importantly, there's no effect on human cells because humans get dietary folate and don't rely on PABA in order to make their folate compounds. So here's a slide showing how bacteria convert PABA into tetrahydrofolate to use for the synthesis of DNA. The first step involves an enzyme called dihydropteroate synthase, which converts PABA into dihydropteroic acid. That is then converted into dihydrofolic acid, which is converted by bacterial dihydrofolate reductase into tetrahydrofolate. So sulfonamides block this first step. They are competitive inhibitors of dihydropteroate synthase because they mimic the structure of PABA. There's a related antibiotic called trimethoprim, which is often given together with sulfonamides, and it blocks the bacterial dihydrofolate reductase. Now, I just told you that methotrexate blocks human dihydrofolate reductase. Trimethoprim, on the other hand, works on bacterial dihydrofolate reductase. It has a much higher affinity for the bacterial enzyme than the human enzyme. Another tie-in with the biochemistry of thymidine involves a deficiency of the vitamin folate. When you are deficient in folate, the main effect is loss of deoxythymidine production and therefore less DNA production. RNA production remains relatively intact because it does not require thymidine. As a result, these patients classically get a macrocytic anemia. They have fewer red blood cells because the red blood cell precursors cannot synthesize DNA and divide, but the cells are large because RNA production and protein production remains intact. Another consequence of a folate deficiency is a neural tube defect in pregnancy. Women who are pregnant need to take folate because their babies need lots of thymidine in order to grow. So if women are deficient in folate, the classic finding in their baby is to have a neural tube defect, and I talk in more detail about this in the neurology modules. The final clinical tie-in to thymidine biochemistry involves the vitamin B12. So vitamin B12 plays a role in conversion of uridine into thymidine. I told you before that you need to maintain levels of N5-N10 tetrahydrofolate in order to continue converting uridine into thymidine. Well, you need folate in order to maintain those levels, but you also need B12. The reason you need B12 is because there is some conversion of N5-N10 tetrahydrofolate into N5-methyl tetrahydrofolate, and B12 regenerates that back into tetrahydrofolate. So if you are deficient in B12, all of your folate will get trapped in this N5-methyl form, and you won't have enough N5-N10 tetrahydrofolate around in order to convert uridine into thymidine. So I've summarized these points on this slide here. B12 is required to regenerate tetrahydrofolate from N5-methyl tetrahydrofolate, and a deficiency of vitamin B12 leads to a methylfolate trap. This means you lose synthesis of thymidine and you will get a megaloblastic anemia, just like I described before for a folate deficiency. One way you can distinguish a B12 deficiency from a folate deficiency is by looking for neurological dysfunction. When you're deficient in vitamin B12, there is a characteristic demyelination that occurs. And I talk about this in more detail in the neurology modules, but for our purposes here, just know that there is no neurological dysfunction associated with folate deficiency, but it is associated with B12 deficiency. In addition, you should know that you can overcome a B12 deficiency with high folic acid intake. If we go back to our overview slide here, when you're deficient in B12, your folate will get trapped as methyl tetrahydrofolate. However, if you consume enough folate in your diet, this will get converted to N5-N10 tetrahydrofolate, and it will continue to convert uridine into thymidine and overcome the B12 deficiency. When you have a patient in whom you suspect a folate or vitamin B12 deficiency, you will often measure the plasma levels of the amino acid homocysteine or another molecule called methylmalonic acid. And the reason you measure these is because you can use them to diagnose a folate versus a B12 deficiency. And in order to understand how to interpret these, we need to look at a little bit of the chemistry of these two molecules. So folate can get converted to N5-methyl tetrahydrofolate, as I showed you before, and then B12 can convert this back into tetrahydrofolate. When B12 does this conversion, it turns homocysteine into methionine. This means that a deficiency in either folate or vitamin B12 will lead to very high levels of homocysteine because this entire process will not be occurring as it should. In addition to this function, B12 serves another function of converting methylmalonyl-CoA into succinyl-CoA. When you consume fatty acids that have an odd number of carbons, like 9 or 11 or 13, those fatty acids will get converted into methylmalonic acid and then methylmalonyl-CoA and then succinyl-CoA so that they can go into the TCA cycle. And vitamin B12 carries out this function for cells. So if you are deficient in vitamin B12, your level of methylmalonic acid will become high because B12 can't perform this function. So as you can see from this discussion, when you're deficient in either folate or B12, your homocysteine level will get high, but only in a B12 deficiency will the level of methylmalonic acid become high. So I've summarized these points on this slide here. For homocysteine, both folate and B12 are required to convert homocysteine to methionine. This means you will see an elevated homocysteine level in both vitamin deficiencies. For methylmalonic acid, B12 converts MMA to succinyl-CoA. So in a B12 deficiency, you see a high MMA level. In a folate deficiency, you see a normal MMA level. And then finally, here's a table to show you the differences between B12 and folate deficiency. This is very high yield for step 1. They love to ask you to distinguish between the two vitamin deficiencies using homocysteine levels and methylmalonic acid. So in both deficiencies, you will be anemic and you will see a low red cell count. In both deficiencies, it is a megaloblastic anemia, so the MCV level will be high. The homocysteine level is elevated in both disorders, and then the MMA level can be used to distinguish between the two because it is only elevated in B12 deficiency. I'll finish this module with a few general points about megaloblastic anemias. In megaloblastic anemias, you are anemic, you have a low crit, and you have large red blood cells, which are represented by an increased mean corpuscular volume. Another characteristic finding is hypersegmented neutrophils, and I've shown one on the bottom of the screen here. And you should know that megaloblastic anemias are commonly caused by defective DNA production. So you can see them in folate deficiency, you can see them in B12 deficiency along with neurosymptoms and high levels of MMA. You can see them in erotic aciduria, where you have dysfunction of the synthesis of pyrimidines. You can see them secondary to drugs that inhibit thymidine synthesis, drugs like methotrexate and 5-FU and hydroxyurea. And you also see them in patients with HIV who are taking zidovudine. Zidovudine is a nucleoside reverse transcriptase inhibitor, but it is a mimic of the nucleotide thymidine, and thus it can block the synthesis of thymidine in cells and cause a megaloblastic anemia. And that concludes our module on pyrimidine synthesis.